Hello, I'm Eric Lander. I'm the director of the Broad Institute. The Broad has been responding to the COVID-19 pandemic in many ways. In addition to our scientific and diagnostic activities, we've also been holding virtual town halls to keep our community informed. Professor Deb Hung recently updated the Broad community about what we know about the virus and the pandemic. Dr. Hung is a core faculty member at the Broad Institute and co-director of the Broad's Infectious Disease and Microbiome Program. She's also a professor at the Mass General Hospital and the Harvard Medical School, and she's a physician at the Brigham and Women's Hospital, where she's played an important role in its COVID-19 response. We found her talk so helpful, we decided to share it more broadly. Here's Deb's talk on May 20th.
So here we are, the result of 30 kilobases of RNA in about 11 weeks into it, where, just 11 weeks ago, we were in the auditorium, as Eric was saying, with the first town hall. And now here we are virtually, all of us with longer hair, a few of us with more white hair. So let me start with where we've started in every town hall, and actually just to reference where that we are with regards to numbers of cases. Here in Massachusetts, where we started the first town hall, there were 2 cases, next around 5,000, and now humblingly almost 90,000 with significant numbers of deaths. And you probably all follow these numbers almost on a daily basis. Here's another way to look at where we are now, and these are essentially the trends of cases on a daily basis from some key countries. I want to note that each of the axes is different and scaled, but the point is the shape of the curves that you can see. And so here we are in the United States. Fortunately, we hit the peak and we're on a plateau, slowly declining. And I just wanted to call attention to that as opposed to some other countries that we've been following closely. Obviously, here is China. South Korea got a lot of attention for how they did well. Sweden, as you know, got a lot of attention because they actually made the deliberate decision not to close down the country. Germany, again, has done well, and then Italy, which also had significant mortality. Just a few things to note on this is that Singapore, which was initially thought to be doing well and coming down, we have to pay attention because they're getting a slight uptick now, thought to do to travel. And so we have to think about that carefully when people start getting on planes again. And again, China, just a few comments because as you probably all have read recently, and I remember when I saw the first news report that there's new outbreaks there. And it almost made me freeze for a moment, anticipating what could happen as we reopen. And then another similar way to look at it is on the state level as we think about the individual states opening, because indeed we have we're more of a federation of states. And here's Massachusetts again. What is providing support for beginning to gradually and cautiously open is indeed that we're on the decline here. Let's not ignore the fact that the number of new cases each day is still far higher than the time that stay-at-home policies were implemented. So we're not nearly out of the woods, and we clearly can't go back to life as normal before the stay-home policies were back in place. But this is to contrast it again with other states, and I'm sure all of you have been following this, that Texas is opening in a relatively large way, and yet the shapes of their curves are concerning. And in contrast, folks like New York and New Jersey, which were hit hard, are at least appear to be on decline, which is reassuring. Okay, so what have we learned since the last time we met? There's lots of data coming out in various ways and various numbers that are making it hard to really grasp what the full picture is. I think that one of the messages is that what percentage of the population is affected is going to depend on where you are, how you're testing, what test you're using, and then how you're selecting the population that you're testing and drawing conclusions from. So just give you an example of kind of where you'll see reports where the numbers appear to be all over the place is there was a study out of Santa Clara using serology that is measuring antibodies and reported pretty low numbers. In contrast, in New York City, where we know that the numbers were much higher, there was one report where, measuring women who were coming in, who were pregnant and coming in to deliver, by measuring whether they had virus or not, they reported 15% of the population had that. There's a more recent, again, serology antibody study in New York City, 25%. And you may have read in the news that these types of studies are now ongoing in Boston. And so there was a report, got a lot of attention, to say that based on serology testing in Chelsea, 30% of the people tested were positive based on antibodies, but then there are other studies, including one that the Broad has been involved in the same Chelsea area where it was only 3%. And that really has that we think it's varied depending on not only the test that's used, but also whether one was standing in the public, in parking lots collecting versus going into door to door. And then again, Boise, Idaho, a place where the density of people is much lower, the reports are around 2%. But this is all to say, look, the numbers vary greatly, and there's a lot of factors that go into it, and we're still trying to kind of wrap our brains around it. But the goal of understanding all of these numbers is to understand how far are we from getting to herd immunity. Or herd immunity is this concept that if enough people in the population have had it and are hopefully immune, then the likelihood that someone who's infected will encounter someone who's not immune and will spread decreases. And the estimates are that at least around 60% of the population will need to be immune in order for this to be effective for SARS-CoV-2. But we do have to understand, what is the cost of getting to herd immunity? Because it means that people are having to get infected to develop immunity. And so it's really sobering when you think about what it would take to get to 60% of the population infected. If you believe here that New York City is truly around 25% of the population has now been infected, and yet we still need to get to 60%, even this 25% has come at the cost of 0.2% of the New York City population dying. This is not 0.2% of people who got infected. This is 0.2% of the entire New York City population has died from COVID-19. So herd immunity is an important piece, and one way to get there is through someone infecting the next person, or where we're all hoping for is the development of a vaccine. And so all of this is predicated on the idea that there indeed is going to be immunity to this virus. So promising developments. There are some promising signs since we last met. I will admit it's a little bit hard to really wrap one's brain around science by press release, but that's really kind of the level that we're on right now. So I just want to comment on two kind of very important events that got a lot of attention in the press. The first, as many of you have heard, is the performance of Gilead's remdesivir in patients. The data is not yet clear, but being human as we are and looking for hope, one wants to be optimistic about what came out from the remdesivir trials. The particular trial that got a lot of attention with NIH was a randomized controlled study that actually enrolled more people than the other smaller trials that were reported. And what was the significant finding? The significant finding was that people seem to be recovering in 11 days versus 15 days. So a small shorten of the duration. It didn't show statistically significant decrease in mortality, although there was a little bit of a trend towards that. So why is this encouraging? It's encouraging in that it suggests that indeed remdesivir, which was shown to have activity against the virus in the lab, in vitro, indeed has antiviral effect in humans, which is encouraging. But there's still many unknowns. How do you use it? How are we going to use it to not simply shorten the duration of symptoms, but it's actually, how are we going to use it to change mortality is still an open question. and that's going to require more study. Many of us believe that based on how other antivirals have worked, such as the drugs against influenza, that the key is going to have to be that people have to be treated early. And so, how you connect all the dots of remdesivir, which is an IV drug, to getting to patients early is all something that has to be worked out, even as there is limited supply of remdesivir. The second finding in report, as I'm sure all of you have seen, is the phase 1 reports of the Moderna coronavirus vaccine trial, which is Moderna's RNA vaccine. Now, be aware that Moderna has actually never produced a vaccine that's been that's actually used now in patients. But they had a head start in this because they had used their platform and were actually trying to develop a virus or a vaccine against MERS, right? Another coronavirus. So let's just remember what the point of phase 1 is. It's really to assess, get some initial safety data as well as a dosing, right? Figuring out what the proper dose is. And so of about 45 people that they tested, they said that 8 healthy volunteers indeed had invoked an immune response that's comparable to what people who have had coronavirus infection before, this idea of convalescent patients. Again, it's hard to know based on press release without seeing data. And so, we have to interpret this cautiously. And that's because we actually know that people who have gotten the COVID-19 infection, their immune responses, antibody responses range markedly from, quite frankly, some people are infected that we don't measure any immune response afterwards, to those that have very strong responses. And so when Moderna says, 8 healthy volunteers had a response that's comparable to convalescent patients, and that range is so enormous in convalescent patients, it's actually quite hard to know how to interpret it. So stay tuned, but it is an important first step, and there's other companies lined up in getting animal data on their various vaccines as well. Okay, what else have we learned since the last time we met? Do we know more? So when are people infectious? What we're learning is that people are indeed probably infectious a few days before they have symptoms, and they can be infectious afterwards for a period of time. The median time is probably 5 days. There's now literature suggesting that if you test people with the viral test, that in fact they can test positive for almost 40 days. But let's remember that viral test is looking for nucleic acids and not actually virus. And there's actually some suggestions that in fact there isn't a viable virus at these very late time periods. And certainly there's the hope and thought that at these late time periods people are not infectious. But this is what drives the CDC guidelines for if you're infected. The numbers of days that you need actually to continue in quarantine, or days without symptoms, which is 7 days since diagnosis plus another 3 without symptoms before you can leave quarantine. Who do you get it from? So there's this notion of close contacts, and it's I'll show you a little bit later about what derives this notion of 6 feet as being the radius of what a close contact is for about 15 minutes. Again, data is coming out now, particularly from China, that the predominant means of spread is actually household contacts or family members. So it really is really about close contacts predominantly, and less, I can't say zero, but certainly less concern about the random person that you meet, in the grocery store or in the T or an elevator. That's not to say that it's not at all, but certainly there's much less risk there. Can we get reinfected? So that's the big question. It gets back to, is there immunity after infection? And so this really bears watching very closely. You probably have seen that there were reports initially in South Korea suggesting people were getting reinfected. And then there was some debate of, well, could that just have been could that have been a technical issue with the testing, and that people had really never tested negative before they had a second test that was positive? There's now another report report that's a little bit more concerning, and that's actually on a naval ship, the USS Roosevelt, where there's a number of people who were tested, who tested positive, and actually had a long period, had several tests that were negative, and then retested positive. And so we need to really watch that closely and what that might mean. So is there immunity? That's really the $60 million question. We still don't know, but we're beginning to get some windows into that, certainly developing tools and platforms to be able to begin answering that, and looking at the roles of neutralizing antibodies, and even some literature on the roles of T cells. So let me just shift quickly a little bit to this idea of how to reopen, and how to reopen as safely as we can. Because these same guidelines that you're seeing everywhere are going to be applied at the Broad, as Eric has suggested. This notion of health screening, and this has been in place at the hospitals actually for quite a while now, where there's an online app where you have to be actually asked, do you have any of these symptoms, and fly through this in order to get approved to come into the building. It's the number of symptoms is always expanding, and it's because we're still learning about the disease. Just an interesting anecdote. I still remember the day that Aviv called me up to say, Deb, the receptor that the virus needs to get into cells, it's a lot on the cells in the nose, and then the next day, the reports started coming out about the fact that people who had COVID-19 infection, many of them had lost the ability to smell. And so it was actually a little bit of funny experience for in this case, the science preceded what we were seeing clinically. Obviously, masks and hygiene is going to be an important part of reopening, physical distancing, and then, as Eric has alluded to, is testing. So let me make a comment about masks and what is the role of them. We seem to keep coming on this topic over and over again, and there's a lot of, I think, kind of misinformation about them and distortion of the concept for various reasons. But the main goal is that the masks serve as a physical barrier that blocks large droplets from coughs and sneezes. Again, it means that if you're the one coughing and sneezing, the idea is for the mask to catch many of these, so that you actually minimize the risk of it going into the environment and putting the other folks at risk. Another goal of mask is actually to remind you not to touch your nose or your face or your mouth. So if many of you remember from the first town hall meeting that we had, when we were all in the auditorium at the Broad, we had concluded that Roby needed to give Eric some kind of remedial lessons on trying not to touch his face. But habits are hard to break, and so now we're going to try the next intervention, and is to have Eric wear a mask. And then follow the last one is probably just as important as any other, and that is it serves as a powerful social cue to remind everyone to be careful. This notion of physical distancing, just as much as people have heard more about nasal swabs than they ever thought they would want to, so too have we heard about respiratory droplets. But just to know the thought right now is that the virus is spread through respiratory droplets, which is produced by talking, singing, coughing, sneezing, laughing. And the key of what they define a respiratory droplet is the size of it. It's about 5 to 10 micrometer. And so the importance of that is actually that they're big enough that gravity will actually pull them down and remove them from the air where people are breathing, which is in contrast, for example, to aerosols. So the studies on respiratory droplets have shown that they travel about 3 feet, which is what generates the CDC guideline, and the ones that the Broad is going to impose of about 6 feet. Now, this is not a hard and fast rule. You can imagine if someone is coughing really hard or sneezing really hard, you can actually go much further than that. But this is actually just this is thought to be a reasonable compromise of distance. And because they settle to the ground, they're in the air on the order of about 5 to 13 minutes. But again, many people are continuing to study this. Comment about interpretation of tests, right? Viral tests are the ones that Eric are talking about. And indeed, this is the clinical diagnostic tool that everyone is using, and what Stacy and Niall have gotten up and running at the Broad. What this tells you is if you have virus. If you have current infection, except for the small caveat I made about, could you still have nucleic acids, but not transmittable virus there. But this is current infection. This is very different than the serology test, which measures whether you have antibodies, which is the CDC, World Health Organization, Department of Public Health have all come out and said, this is not to be used as a clinical diagnostic tool. This is a public health tool because it's really telling you about people who have antibodies that have suggested you have had previous infection. This is telling you about prevalence. What percentage of the population has had infection? Importantly, it does not tell you yet, because we don't know enough, if this provides protection and how long you might have protection from subsequent infection. We just don't know, and that's the critical piece. And so that the notion that you could have a passport that says, oh, serologically, I've tested positive for this, therefore, I get free rein and I can go out and function normally, is just not true. We don't know. We don't know, even if you've tested positive, if that will protect you. And even if you tested positive today, if you're carrying that passport around next month, we don't actually know if you still carry that protection. So, the final messages I want to say is please be careful. Even as we get going again, it's not the flu, despite what you might hear sometimes in general conversations. This is just a little bit of a graph. I mean, it's not the perfect, there was no perfect way to display this, but I'm going to display this based on the number of confirmed influenza deaths each year. So this is here, you can see it's around 15,000 this year in the United States. You will hear these numbers of 20 to 60,000, but you have to know that those are based on CDC modeling, and so we don't actually know the numbers. In contrast, confirmed COVID-19 deaths, this is from the Washington Post, it's 60,000 here. As you know, it's actually over 90,000, so even this is dated. But if you take literally the peak week of flu this year and how many deaths, and then map it to the peak week of how many deaths there were due to COVID-19, you can see that the estimates are 10 to 44 times greater for COVID-19 than flu. It's not the same. And these COVID-19 numbers are done in the setting of physical distancing and shutdown, and it's not over yet. So please be careful. We need to take this seriously. If you look at US mortality right now, it's around 6%, whereas influenza is on the order of 0.1%. So even if you say that, we're only capturing, 10% of all cases because, there's 10 times more people are asymptomatic, that would still reduce the mortality down to 0.6%, and that's still more than flu. Last thing, another reason to take this seriously, we're still learning. There are reports now. Originally we thought, okay, it's predominantly in the elderly, and so all of us might have exhaled a little bit, but now there are actually cases of young and middle-aged people. Particularly in United States, we've seen many more who are actually dying. But now there are actually reports of these folks getting strokes. So completely healthy people who are barely sick with COVID-19 are actually presenting to hospitals in their 30s and 40s with debilitating strokes. I saw this myself at the Brigham, and the thought is that the virus is causing some clotting abnormality and maybe some endothelial abnormality in the vessels of people, and that's what's attributing. But we don't fully understand it. So it's not trivial to say that we shouldn't dismiss and say, oh well, we're young, we're safe, let's just get it and get it over with. And then we also thought that kids were predominantly spared, but as you probably all are seeing, that there's now a link between this inflammatory condition called Kawasaki's disease, and in children, it's this hyperinflammatory syndrome that's thought to be immune response. And so we're just learning about it now and its association, but it's putting children in ICUs. And so we got to take this seriously. So, as we reopen, we continue to appreciate your cooperation and working with us in all of this. And sometimes it will seem extreme, but we want to err on on the side of caution. So I just want to end. This is the third time that I've spoken, and so I really need to give a shout out to Sharon Wong and Moby Bhattacharya they're the ones who pull all the data, put together all the slides for me. Many times the night before, probably even more often the minutes before the presentation. And so, if you see them, please take a moment to thank them and express any gratitude for their efforts. And if you don't recognize them this way in the coming days and weeks, you might recognize them this way.
We hope you found the talk useful. I want to say a big thank you to Deb, who's played a central role in shaping the Broad's own response. It was her idea for the Broad to ramp up large-scale COVID-19 testing, and she's also organized a weekly public lecture series on COVID-19. In addition to all that, she's been treating patients. And she's even taught me to stop touching my face so often. Thanks, Deb, and thanks to all of you.